So very warm welcome and a good morning to everybody uh, to this next edition of Let's Talk. We have a very interesting discussion lined up today with Dr. Revathi Raj, who is presently working with Apollo Hospital in Chennai. So let me just give you a brief introduction about Dr. Raj. She is Dr. Raj, as I mentioned, works at the Apollo Specialty Cancer Hospital in Chennai. She did her MBBS from Madras University in Chennai in 1991 and her DCH from MGR Medical University in 93. And thereafter, she did her FRC pathology from Royal College of Pathologists in 2008. Dr. Raj is credited with performing one of India's largest sequence of bone marrow transplant, with more than 2,000 successful transplants under her experience. She's regarded as one of the best specialists for pediatric bone marrow transplants in India. She has been working successfully in treating pediatric cases of thalassemia, hemophilia, sickle cell anemia, aplastic anemia, and leukemia. And she has particular interest in children blood disorders. So thank you, Dr. Raj, for joining us today. And over to you to take us through your journey of dealing with rare diseases patients.
So namaste, everyone. And I'm really grateful that you've taken Sunday morning out to learn about what are the diseases that need help. I think very few people give time, so it's easier to give anything other than our precious time. So thank you for this. I'm just going to spend about 10 minutes to talk about thalassemia and what we do at the VHS Thalassemia Center in Chennai. And so first I want to begin with saying I really don't know why government put thalassemia under rare diseases. It's by no means a rare disorder in India. Every year, 10,000 new babies are born with thalassemia major. And what is actually rare is knowledge about thalassemia. So the disease is not rare, although it is very common, more common than we would like it to be. It's the knowledge about it is really rare. So that is the sad thing. So if at all there is any message from this group, what we would like to take forward is how to prevent thalassemia, because this is a highly preventable disorder using extremely simple measures. Can you all see my screen, please?
Yes.
Yeah. So yes. This is the VHS Thalassemia Center. It was it's in the Voluntary Health Services campus in Chennai, and this is Vanakkam from Chennai. So I'm just going to give you a little outline about what is thalassemia. I know you're all dealing with different disorders, but this is a blood disorder, and the blood has cellular components, red cell, white cells, and platelets, and it's suspended in the yellow liquid called plasma. And all of this is made inside the bone, which we call bone marrow. And every day, every minute of every day, we make new blood, and red cells live in our body for 120 days, white blood cells for 2 days, and platelets for 10 days. And to make every cell in our body, we need one gene from our mother and one gene from our father. And once these red cells are made, the hemoglobin, which is the protein in these red cells, help deliver oxygen to every part of our body. So these are basically like postmen, and they carry the oxygen, and so there's an iron part and a protein part which bundle up the oxygen and carry it. And out of the 46 chromosomes that we have, chromosome 11 and chromosome 16 are important to form the two parts of the hemoglobin, which has the alpha chain and the beta chain. And when one beta chain is missing, we call them a carrier, and when both the beta chains are missing, we call them thalassemia major. So these are called hemoglobinopathies, which means changes in the hemoglobin. You would have been heard of another blood disorder called sickle cell anemia, and thalassemia is a genetic blood disorder where the child is unable to produce red blood cells. And the reason why we have to worry is it's a lifelong problem, these genetic disorders, which can't be cured by medicine. And the one child that is affected in the family is a huge strain for the rest of the family, and it is a global problem. And the patients are tied for life. Without transfusions, they cannot live. And the most important message, as I said, is it's such a simple disease to prevent. Just looking at a blood test when the lady comes for pregnancy booking can go a long way in prevention of new births. And it's so simple and effective, and it's not being done. Why do we have thalassemia in our country? Both sickle and thalassemia genes are related to malaria. So you see worldwide, we don't see sickle or thalassemia in the Caucasian population. It's more in the Southeast Asian countries and sickle more in Africa, because being a carrier or lacking the one gene to make red blood cell gives you natural protection against malaria. But if two carriers get together to form a baby, then the chance of both the missing genes going to the baby is about 25%. And because of this, the baby gets affected. And as I said, there are 10,000 new babies every year born in our country. And it's very sad because a majority of them, they just go away as infant mortality. It's not even recognized. Very uncommon in South India, but more common in Sindhi, Punjabi, Gujarati, Bengali, and Saurashtrian population. But still, we are the thalassemia capital of the world now, because husband carries one defective gene, wife carries one defective gene. If they are lucky, both their good genes go to the baby, or if they are unlucky, both their defective genes go to the baby. The baby will look beautiful and normal at birth because the fetal hemoglobin, which they have, carries them through to 3 to 6 months. After 3 to 6 months, their genes should kick in. And when they don't have the genes, then they are diagnosed to have thalassemia. And above all, the carriers don't have any symptoms. They are normal. Maybe during pregnancy, they are found to have mild anemia. And very famous people like Amitabh Bachchan are thalassemia carriers. So you don't have any symptoms at all. Just this one education of our physicians who take care of pregnant women. If somebody comes with a blood test during pregnancy, check their hemoglobin. What is the size of the red blood cell? Is it low? That is MCV. Then it could be iron deficiency. But at the same time, there is something called RBC count. Look at it. If that is low, it's iron deficiency. But if that is high, you suspect this could be a thalassemia carrier person, and counsel them to say, if you have thal carrier, bring your spouse. If you both are carriers, your baby could be affected. If you alone are a carrier, there is no risk to the to your baby. And this simple, effective prevention method, if every primary care physician knows in our country, it would go a long way. They can't make blood, so the blood looks all disorderly. And just simple blood tests can prevent it. But if we can't, then once they are diagnosed, it's lifelong monthly blood transfusion. So prevention should be our priority. And this is HPLC, which we can use for mass screening, because this is a very simple blood test. What we use for diabetics to do HbA1c, to see what their sugar control is. So it's not like the test is difficult to have access to also. So if we have the HB electrophoresis machine, we look at this blood test called A2, and if it's normal or high, this A2 is elevated in carriers, which is the diagnostic part. So the baby has only fetal hemoglobin. They can't make adult hemoglobin. Our country is a vast country, and there are 400 different genes in different parts of the country that can cause thalassemia. But there are 5 common genes. So it's very, very easy to do a confirmatory diagnosis and offer prenatal. So in October 2006, we formed this parent and patient group in Chennai called the VHS Thalassemia Center. We had parents and patients, the older patients, and volunteers from the community the unit is attached to the blood bank, and the blood bank in charge, Dr. J. Balasubramaniam, was instrumental in inviting me to start this, because he felt the donor's blood should benefit patients, and he could see how they were suffering without access to safe blood transfusion. So this was the transfusion center then, and this is the current transfusion center 15 years later. We now have a 20-bedded facility, what started as a 2-bedded facility. And the patients come there for monthly blood transfusion. We may think it's very simple to provide 1 unit blood, but we have to make sure their hemoglobin is above 9 so that the children grow, they don't have bone changes, and they don't form big spleen, and the blood has to be safe. We don't give whole blood. We remove all the white plasma from it and give only the red blood cells. And we counsel new parents to have voluntary donors for their child, because if they are linked to the same donors, then the chance of getting viral infections through blood transfusion is less, and the hemoglobin should be kept above 9. Otherwise, as you see, this is a 15-year-old girl on the right and a 15-year-old boy with thalassemia who's had only 4 to 5 grams hemoglobin. They don't grow, and their spleen becomes quite big, and then they have to have a spleen operation. So the morbidity is very high. They pull along, pull along. Every bag of blood has 200 milligrams of iron. So this is where the problems of thalassemia come in. All government hospitals are able to give blood transfusion optimally, but the iron part does not cause symptoms. So it just keeps accumulating in the liver, it keeps accumulating in the spleen, and sorry about that. In all the hormone-producing glands of the body, and liver, heart, and the hormone-producing glands. So that's why they're short, their skin gets pigmented, they present eventually, they die in their teenage because of liver and heart problems, and a lot of hormone-related issues. So by the age of 2, they have to start taking tablets to reduce iron. And this is a big burden because these tablets are expensive and they have to be given in a consistent manner. And before, we used to have only injection, and the parents had to give the injection all night through a needle and a pump. The pump cost 40,000 rupees. Parents had to poke the child who would cry to say they don't want to have injections. So compliance was very poor, and a lot of them had high iron. But now we have tablets which they can take easily. One is called Deferasirox, another one is called Kelfer. And sometimes we combine, have 2-3 days a week of injection, 2-3 days of tablets, so that the iron is reduced optimally. Iron overload does not cause symptoms. So we have to call the families, educate them as to why it's important to continue taking the medications correctly. Because of blood transfusion, hepatitis C is also a problem despite screening, but now we have treatment for hepatitis C. Because it affects the heart, we have to do joint clinics with the cardiologist to check how they're progressing and how the heart is. And we need staff that motivate others, patients that motivate others to continue, because an apathy sort of sets in. One of the main curative options for thalassemia is changing bone marrow. So the stem cells which produce red blood cells, white blood cells, and platelets, if they are changed, then they can come off needing blood transfusion. This is a one-off curative procedure. So to have somebody's bone marrow, we need to be matched with them. And that matching is called HLA typing. Only 1/3 of our patients have a matched family donor. So sometimes people are going abroad to have savior siblings because they do genetic embryo selection so that they will be matched with the first affected baby. But those who are lucky have a fully matched sibling naturally. For those who are not lucky, then there are unrelated donors worldwide, including one in Chennai called Datri. And these are voluntary donors that help patients with blood disorders like thalassemia and donate their stem cells to help cure them. Even if they don't have a matched unrelated donor, we are now able to transplant them using half-matched donors, a mother or father or brother or sister. And this is also effective. The problem is transplants cost 15 lakhs to 30 lakhs, although they are one-off procedure. And the bone marrow transplantation process, thankfully in Tamil Nadu, we have it registered under the Chief Minister's Health Scheme for the whole of India. Coal India gives 10 to 15 lakhs for those who need a transplant through the PM fund. Even after they are having a transplant, they need to have follow-up care long-term to see how they are growing, because this is a little girl whom we transplanted when she was less than 10. We have to see that they're growing optimally and all their organs are functioning optimally. The future is bright for blood disorders because we are now able to introduce the missing gene through gene therapy. So hopefully the expensive gene therapy process, which is over 2 crores abroad, we will have our own Indian version very soon. So families are waiting with bated breath for gene therapy. But looking beyond medicine, what is the quality of life? Every year, these patients have transfusion. You can see the patients who have had transfusion, their quality of life, if you look at the bottom column, the summary score is very poor. And it worsens beyond 18 years. So initially, it's easy to bring a child for transfusion. But when they're teenagers, to help them come during exams, during festivals, it's very, very tough. And quality of life is poor over 18 years. So we have to focus. And since transfusion got better, we have a whole bunch of adult thalassemia patients. And the cost of care keeps increasing every year against a one-off high transplant cost. So this is what this picture denotes. The time for awareness has come because so many studies have shown, if we look at the caregivers, only 15% know that it's a genetic disorder. We have to screen the family members, tell them their brothers or sisters can be thalassemia carriers, do extended family screening. So focus on the high-risk groups in India so that we can avoid our population being the thalassemia capital of our world. This is an area in Tamil Nadu called Chitteri, and with the help of Rotary International, we did a camp where 23% of the population are thalassemia carriers. Most of them thought there's something wrong with their water. That's why the children were falling ill. And a significant proportion of these tribal people come all the way to Chennai for transfusions every month, which is very difficult for them because that one day they lose their daily wage labor and they have to come all the way to the city, for which initially they walk 6 kilometers to their bus stop. Then they take a bus to the railway station, take a train from there to Chennai, and another bus from the Chennai station to our center. So it's something that we subsidize, but still it's a big journey. We can do prenatal diagnosis, definitely prevent 2 children in one family being affected, definitely. And we do a lot of school camps and awareness camps to talk about thalassemia. The problem in our country is if a young girl is being told that they are thalassemia carriers, nobody wants to marry them because they think she has a blood disorder. So these camps we do with a lot of sensitivity, because if we tell someone they are thal carriers, then their chances of getting married also goes down. So this is again an issue which we are trying to address. The antenatal diagnosis costs 25,000. So we have an MOU with a local center where we sponsor, because we have to focus on prevention. The curative options are expensive. So whoever needs prenatal diagnosis, we find sponsors to make sure that the baby is unaffected. And this is our amazing group of nurses, physicians, volunteers, and admin staff who come and help. And our work was recognized by the government of Tamil Nadu, for which we got the gold medal honor recently. And the patients, we have an amazing long-term association, because we see them from the age of 3 months, and our oldest patient is 39 years old. And funding was initially an issue, but since we have got an MOU with the government of Tamil Nadu, there is about 50% of the funding comes from the government and another 50% from long-term volunteer sponsors, and the first of whom is my brother, who sends money from the US. So he's the one who put in the seed money to start all this work. So thank you for your patient listening. I'm happy to answer questions.
Well, thank you, Dr. Raj. I think that was very interesting and a eye-opener for all of us, because though we had heard about thalassemia, but the dimension which you have shown to us was really, at least I was not aware of all these aspects. And thank you for making it so simple and easy to understand, because I think it's most of the times when we hear these kind of topics from a doctor, they get into a lot of technicalities, which most of the time as parents, it goes over our head, but you made it very simple. Thank you very much. So any questions from any of the participants? I have one over here which says, could you please tell us how you got government funding for the kind of for BMTs or for the treatment which was required?
So I think this is the way forward, to have public-private partnership, because within the government hospitals to provide tertiary care is very difficult. So if we have MOUs to have private-public partnership, so I think Tamil Nadu and Kerala are the most advanced states for public-private partnership. Punjab is slowly getting there thanks to efforts of physicians there. But it took a lot of going and meeting the government people. So this was all started in 2010. And I think a lot of the tribal people voiced their difficulty, how they were struggling. And once the then Chief Minister, Mr. Karunanidhi, he heard what their situation was. So he initiated, and at that time it was a small amount, and the next CM increased the allowance, and the current one, they have access to care right from diagnosis to transplant. So it didn't happen overnight. It's taken about 12 years to get to where we are. But it has to be repeatedly represented.
Okay. Any more questions?
Problems we face all the time are getting blood donors, because it's not 1 day, 2 days. They need regular blood donors, long-term, lifelong. So that is one problem we faced, especially during COVID. So many of our patients couldn't travel. They couldn't get access to blood donors. It was a serious struggle. And the second one is when they're in their 20s, finding jobs, because if they know they have thalassemia, finding a job is difficult. And the third is to find a spouse, because some of these young people are amazingly beautiful with a very good job, but still the fact that they have a blood disorder, to find a spouse is difficult. So these are the current challenges. With the gene therapy, what is happening is they have a missing gene, and the bone marrow stem cells from the patient is taken and into the lab. The missing gene is inserted into the bone marrow stem cells by means of a virus, which is very similar to the HIV virus. You know, HIV virus gets into our blood, but this is a sort of an inactive version of the HIV virus. And as the virus tends to join with the bone marrow stem cells, it carries the missing gene with it. So the next time they produce blood, the gene is also incorporated. So what we do is keep this product in the freezer, give the patient high doses of chemotherapy so that all their bone marrow stem cells, which are defective, is destroyed, and these new stem cells with the missing gene is injected into their body like a blood transfusion. And they go into the bone, start making new blood after 2 weeks. So the cost of the gene therapy comes from the technology that helps you inactivate the virus so that it won't cause problems, and take the virus and insert it into the stem cell. So that is the biggest cost, the technology, because it's all patented at the moment.
Is this under trials presently, or has it already been approved in India?
So in the West, there is a company called Bluebird Bio, which it's all FDA approved. So in India, the initial, because we can't use the same vector, that vector is patented, that viral vector. So we are using our own viral vectors, and that is all under trial at the moment through, through the ICMR trials.
Okay. Any other questions from the participants? Any more questions, queries?
But if there is any way we can give a voice for prevention, I think that is something that would be the way forward for our whole country. Because, for example, a small island like Maldives, I can't go and register register my marriage without showing whether I am a thalassemia carrier or not. I need to show the blood test, because if I'm a carrier, my spouse is a carrier, then they will say you're at risk of having a baby with thalassemia major. So this is how they've made awareness mandatory.
Okay. Ma'am, I have a question which is related. You mentioned about the challenges that you faced during the COVID period. So how did you manage that? How was, those, as you also mentioned that you require a transfusion once every month. How were the patients coming there? How were the donors? Because it's a voluntary donation. And if they have any kind of restrictions put in over there for them to travel, plus also the risk of catching up with an infection, because you're going to a center where you have all kinds of people and everybody over there. So how did you manage that? How was those conditions managed in this last 2 years of COVID that we've seen?
So first thing that we kept communication channels open. So they had 24-hour access to phone numbers of our lead nurse, myself, and Mr. Ganeshan, who is the admin officer. So they could reach out to any one of the three of us. We found out where they were from. So if they were from Trichy, then which is the local hospital, contacted each of these hospitals in their local area, spoke to those physicians in order to help them with the transfusion. If they decided to give the transfusion free of cost, then they had it free of cost. If they needed to pay for it, then we transferred money or reimbursed them the next time they could travel here. A lot of them needed e-passes to travel from their district to our district. So we sent the e-passes. And so the medicines for those who couldn't come, we couriered the medicines to them so that they didn't have to travel just for the medications. So, and every now and then on WhatsApp, we made appeals for donors to come in little groups and donate, and for the donors to inspire confidence, gave them information as to what all precautions we are taking in the blood bank so that they don't contract COVID from just coming there to donate blood.
Okay. Ma'am, as far as the rare disease policy is concerned, you must have gone through it, where they say that you could probably get a one-time, they've classified into 3 categories, and for one-time treatments, they have given an allocation of 20 lakhs. Do you think is that the way to move forward specifically?
For thalassemia, definitely, because if they have the one-time treatment, if they have a fully matched brother or sister, they stand a 95% chance of getting cured. If it is a half match or an unrelated donor, it comes down to 85%. And before, only 3-4 centers in the country used to do transplants. Now for every corner of India, we have good transplant centers. So we have to make this knowledge more available for patients so that they can appeal for this fund and come out of long-term transfusion. But in the long run, the government can just get budget depleted by doing for thalassemia. Because if you look at, for example, muscular dystrophy versus thalassemia, you'll have 100 times more patients. So the way forward would be for prevention.
But I mean, I'm saying, yes, prevention is, of course, better than cure. But what I'm saying is if a person already has thalassemia major and needs a bone marrow transplant, have you had experience where they have claimed under RAM?
No. Even this is the first time I know about it, because the only, for us, we can do through our government scheme, the patients who are coming from neighboring states, Kerala, Andhra, since we don't have government schemes with them, all we have done so far is crowdfunding.
Okay. All right. Any message that you would like to give to the way forward about how we should be dealing with the government to increase the awareness and to try and see how we can prevent thalassemia?
I think that little thing I said about looking at simple blood tests, and if we just say that simple blood tests can prevent thalassemia, and that can be included as part of the blood test at booking pregnancy, or it can only be done through the government. We as private practitioners, we can't make the change. But if it's a governmental regulation and it's law, like HIV testing was made mandatory, it would make a huge difference.
Okay. All right. Any other questions? Any other queries from the participants? Vaishali ji, you have any question?
I had actually, I had given my question in the chat, but okay, can you throw some light on, besides your program, what are the other programs, and in which states is it much more prevalent? I mean, not thalassemia, but the programs are running well.
Okay, so the Hyderabad Sickle and Thal Society is huge. So they have a transfusion center. Then in Tamil Nadu, we have the two big ones, Coimbatore and Chennai, to which I'm linked. Then Maharashtra has very good thalassemia centers. Bengal has in like Siliguri and Kolkata Thalassemia Society, because the burden is very high in Bengal. Gujarat also has for sickle and thal. I think Punjab, it's being led by Dr. Praveen Sopti. Again, the stigma is very high, because if a family is seen to have a blood disorder, then it's almost like the initial days of COVID, where no one wanted to know you, and being associated with you means that, I don't know, it's the stigma has been high. So that is the problem. So we have to overcome the stigma and have more awareness and education days.
So just to follow up to this, what I'm thinking is probably targeting students in schools.
Yeah, so that's what I was telling you about. Once we've done that and we've counseled the teenagers, it has become an issue, because if they carry a card saying they're THAL carriers, then they've had difficulties in finding a spouse, because our country, I don't know how to overcome this. So in fact, one of the areas in North Madras, Saukarpet, where we did the camps in the Jain schools, they stopped us from coming back, because they said it's causing implications in the future, because they all got married even when they were in college. And once we've told them about the THAL carrier state, it has been an issue.
Yeah. No. So I was talking more in terms of awareness creation rather than screening. Starting very early in school. I remember when we were in school, it was just a one-liner kind of information about all the blood disorders. So maybe, if it is being such a big issue, also mortality being high or other morbidities, something with the government. Sameerji, what do you think? Is when we are fighting the war together?
I agree, but I think what Dr. Revathi is saying also is interlinked, because the question is, when you create that awareness, and if during that awareness somebody is diagnosed, the problem starts from there itself. So the question is, it's like a the parda system that we followed. As long as the parda is there, where you have it or you don't have it, it's an unknown thing, and you don't know about it, you are okay. So you're closing your eyes towards the factual position that you actually are being, you are suffering, or you would probably suffer in, once you get married, and the chances of your siblings or your children having a problem like that. And what she says is actually right. The moment it's for boys and for girls. I mean, we see that ourselves in our group also, because our again, it's ours is also X-linked and problem that we see in girls only. A lot of this, they don't want to even associate themselves with what is happening around their environment. They don't want to talk about it. They don't want to disclose it to anybody. And which I think what the point that Dr. Raj has touched upon is actually very sensitive, and it's very difficult to be able to convince people as to how do we go about. I can just give you a relative to an example which immediately runs into my mind talking about this. We had this picnic last Sunday, and I was just clicking some pictures over there of all the parents who had come. And there was this family who was sitting with 2 children. And I said, I want to take a picture of yours. Are you okay? They're saying, yeah, we are okay. But they moved away from their children. And I said, I would like to take a family picture. They said, no, we don't want it to be a family snap. You want to take it for our children? We are okay, but not with us. And I just looked at them and I understood what they were trying to say, that they don't want, are you going to put it on a magazine, or are you going to put it on the net? Are you going to be sharing it with others? And we don't want to be seen with our children. So that's the stigma. That's the challenge which is associated with it, to say that, we don't want to be called with children having special needs or having blood disorders, as Dr. Revathi Raj has put up.
I think also, no, it's not something where you lose the children in infancy. They're normal, they're going to school, they're active. So to look at, there is nothing outward which is debilitating. See, if it's like a muscular dystrophy or any other illness, you can obviously see they're struggling. Absolutely. But they look normal. So there is no external features to say that they are suffering as well. And the majority of the distress comes in their 20s and in their when they're older, when the family has formed a bond with them. So actually it's really upsetting for the family, because there are some of them who said that I'm a burden to my family, so maybe I should just go. Because of me, my brothers and sisters are struggling, my parents are elderly, so they are also struggling. So that's how they feel about it.
Absolutely, I agree with you. Amrishi, you had a question? You were talking about the AAV vectors. Amrishi,
so the adenoviral vector, so you have to have a vector that preferentially goes to the blood, and the adenoviral vector goes to the liver. So that is important for hemophilia gene therapy, because you want the liver produces factor 8 and 9. So you want a liver tropic virus which will get attracted to the liver. So here we use retroviruses like HIV, a retroviral vector which likes blood.
Okay, got it. So that's you must be targeting the hematopoietic stem cells, right?
Correct.
To change the gene.
Yeah.
I heard about, I think it's CMC is also doing some research on this, right? Dr. Alok.
This is all ICMR funded. So hopefully we'll have our own viral vector and our own gene therapy. So they have started the clinical trials for hemophilia, but the clinical trials for thalassemia still haven't begun, because the gene is much bigger. It's difficult to get it into the cells.
Okay, but are they having a vector production facility?
Yeah. Still it not reached human trials yet.
Okay, the reason I was asking because our I'm from Muscular Dystrophy Society, PPMD, Parent Project Muscular Dystrophy, and we had a certain projects on running on the muscular dystrophy where we are using AV vectors. So the roadblock is now that we need a large-scale bioreactors and downstream processing for the vector purification. So I thought maybe we can collaborate with CMC well, or if they have the capabilities of doing AV vectors, because that's the one that is used in the muscles. Retrovirus is not the one that has a tropism to the muscles, but it's a AV9 that has. So will CMC be of any help to us in escalating the production of the AV vector? We have already proved the proof of concept. Now we're looking for large-scale production.
Yeah, absolutely. I think you should speak to Dr. Alok, and whatever is the way forward for gene therapy, he will be willing to help.
Sure, I'll do that. Thank you, ma'am.
If you all have any information on how parents can apply for this one-off 20 lakh funding, please share it with me so that we can guide them.
Sure, ma'am, we'll do that.
Yeah.
Okay. Any other question that we have? If not, then we could probably close this meeting. Thank you, Dr. Raj. Thank you very much for this very, very informative session. You've clarified a lot of you've given us a lot of new information, clarified all our doubts. And I think it's been a very interesting and informative session for all of us. Thank you very much.
Carry on the good work, all of you.
Absolutely, ma'am. We'll be in touch with you. Thank you.
Thank you.
Thank you
so much.
Thank you.
Wonderful.
Have a great day. Thank you.
Thank you. Thank you.